This is Lecture 2, Thyroid Storm, as well as Myxedema Coma. These are two endocrine disasters that kill fast and are tested heavily on the boards. Thyroid Storm kills through hyperadrenergic cardiovascular collapse, while Myxedema Coma kills through hypoventilation, hypothermia, and shock. Both require recognition before lab confirmation and treatment in a specific order. So here's the objectives. Our first objective is to recognize thyroid storm using clinical criteria and that Burch-Wartofsky score. Second, execute the 4-drug thyroid storm sequence: beta blocker, thionamide, iodine, and a glucocorticoid. Third, understand why iodine comes after thionamide. Fourth, recognize myxedema coma in the hypothermic, bradycardic, and altered elderly patient. Fifth, give stress dose hydrocortisone before or with levothyroxine in myxedema. Sixth, manage the airway and rewarming carefully. And lastly, avoid the classic board traps. The ED mindset for thyroid emergencies is treat before labs confirm. You order that free T4, the free T3, and the TSH, but those take hours. A patient with the clinical syndrome cannot wait that long. In both thyroid storm as well as myxedema coma, these are clinical diagnoses. The boards test whether you can recognize the pattern and execute the sequence without lab confirmation, the right diagnosis with the wrong sequence, or even worse, treatment of iodine before that thionamide will kill this patient. Thyroid storm is severe thyrotoxicosis with multi-organ decompensation. The classic features are fever, often greater than 38.5 degrees Celsius, tachycardia, often above 140 beats per minute, atrial fibrillation with RVR, agitation, delirium, or coma. Gastrointestinal symptoms including nausea and vomiting and diarrhea, heart failure and pulmonary edema, and a precipitating event. Common triggers include infection, surgery, contrast exposure, iodine-containing medications such as amiodarone, recent radioactive iodine therapy, pregnancy, trauma, and diabetic ketoacidosis. The board concept is the pattern hyperadrenergic patient with fever and a precipitating event. The classic ITE buzzword in the elderly is apathetic thyrotoxicosis, where the patient looks depressed, weak, and weight losing instead of agitated. The mimics that the board love are sepsis, pheochromocytoma, sympathomimetic toxicity, NMS, and serotonin syndrome. The most common precipitants are infection, surgery, trauma, iodine load from contrast or amiodarone, diabetic ketoacidosis, MI, and abrupt withdrawal of antithyroid medications. The Burch-Wartofsky point scale quantifies the likelihood of thyroid storm. 5 categories are scored: temperature, central nervous system effects, gastrointestinal hepatic dysfunction, cardiovascular dysfunction, and the presence of a precipitating event. A score of 25 to 44 suggests impending storm. A score of 45 or greater is highly suggestive of thyroid storm. Akamuzi criteria are an alternative scoring system used internationally. The board concept is that the thyroid storm is a clinical diagnosis. Use the score to support, but not replace, clinical judgment. Treat the high suspicion patient even before the score is calculated. The ITE buzzword in this case is just Burch-Wartofsky. If they give you a score of 45 or above, the test writer is signaling to start full sequence treatment. The thyroid storm treatment sequence is fixed and tested on every board. First, beta blocker for adrenergic control. Second, thionamide to block hormone synthesis. Third, iodine to block hormone release. Give at least 1 hour after the thionamide. Fourth, glucocorticoids. This is to reduce peripheral T4 to T3 conversion and to cover possible adrenal insufficiency. Fifth, supportive care, including cooling, fluids, and electrolyte management. Sixth, treat the precipitating trigger. The reason iodine must come after the thionamide is the iodine given alone could provide substrate for new hormone synthesis. The thionamide blocks synthesis first, the iodine blocks release. Beta blockade is the first medication in thyroid storm and provides rapid symptom control. Propranolol is preferred because it also inhibits peripheral T4 to T3 conversion. Doses are propranolol 60 to 80 milligrams orally over 4 hours, or 1 to 2 milligrams IV every 15 minutes until the rate is controlled. Esmolol is an alternative for titratability or when oral access is unavailable. Load 50 micrograms per kilogram IV over 1 minute. Then infuse 50 to 200 micrograms per kilogram per minute. Use cautiously in heart failure, severe asthma, or shock patients. The board concept is that the beta blockade comes first because it treats the cardiovascular threat immediately. Propranolol at higher doses also blocks peripheral T4 to T3 conversion. which is the bonus mechanisms the boards love. The classic distractor is picking metoprolol or atenolol, which control the rate but not block the conversion. Thionamides block thyroid hormone synthesis. Propylthiouracil, abbreviated as PTU, is dosed at 500 to 1000 milligrams orally as a loading dose, then 250 milligrams every 4 hours. PTU has the additional benefit of blocking peripheral T4 to T3 conversion. Methimazole is dosed at 60 to 80 milligrams orally per day in divided doses. Methimazole has fewer adverse effects but does not block that peripheral conversion. PTU is preferred in thyroid storm and in the first trimester of pregnancy. Methimazole is preferred for routine management. Both can be given via NG tube if the patient cannot swallow. The board concept is to give thionamide before the iodine is administered. Iodine blocks the release of preformed thyroid hormone. The Wolff-Chaikoff effect causes a transient inhibition of synthesis with high iodine doses. Iodine must be given at least 1 hour after the thionamide. Common preparations include saturated solution of potassium iodide, abbreviated as SSKI, at 5 drops orally every 6 hours, or Lugol solution at 8 drops every 6 hours. The classic board trap is giving iodine first or alone. Without proper thionamide, iodine acts as a substrate for hormone synthesis and can worsen the storm. The order is a non-negotiable: thionamide first, iodine at least 1 hour later. The phenomenon of iodine fueling new hormone synthesis in a susceptible thyroid is the Jod-Basedow effect, and this is the ITE buzzwords the boards expect you to recognize. Common iodine lows that trigger storm on test questions are iodinated contrast for CT, amiodarone, or povidone iodine in large volumes. So, glucocorticoids serve two major roles in thyroid storm management. The first is that they inhibit the peripheral T4 to T3 conversion, reducing active hormone. The second role they play is it's treating that potential adrenal insufficiency in the setting of severe hyperthyroid stress. The standard regimen is hydrocortisone 300 milligrams IV bolus, then 100 milligrams every 8 hours. Alternatively, dexamethasone can be used at 200 milligrams every 6 hours IV as an alternative, and it also blocks peripheral T4 to T3 conversion. The board concept is that steroids are essential, not optional, in confirmed or suspected thyroid storm. Supportive care is the foundation alongside the 4-drug regimen. Cooling for hyperthermia, external cooling and acetaminophen, avoid aspirin, which can displace thyroid hormone from binding proteins, fluid resuscitation for volume depletion as well as high output cardiac failure, electrolyte corrections, treat atrial fibrillation with rate control via beta blocker, then anticoagulation per CHADS-2 VAS score if it persists. Identify and treat the trigger. Infection workup, ECG, and troponin for ACS. Pregnancy tests, medication review, ICU admission for monitoring and titration. The board concept is that the storm is a multi-system disease requiring multi-system support. The lab pattern on the board expects is hyperglycemia from catecholamine surge, mild hypercalcemia from increased bone turnover, transaminitis from hepatic congestion, and leukocytosis even without infection. The classic distractor is anchoring on sepsis because of the fever and leukocytosis, but missing the thyroid syndrome underneath. Myxedema coma is severe decompensated hypothyroidism with mortality of 20 to 40%. The classic presentation is the elderly patient, often a woman, with profound hypothermia, often below 35 degrees Celsius, bradycardia, hypotension, altered mental status ranging from just confusion to coma, hypoventilation with hypercapnia, hyponatremia, hypoglycemia, and a non-pitting edema of the face and pretibial areas. Triggers include infection, cold exposure, missed levothyroxine doses, sedative or opioid medications, myocardial infarction, surgery, and stroke. The board concept is recognizing the hypothermic, slow, altered elderly patient as myxedema coma until proven otherwise. The most common precipitant on board's questions is infection, especially pneumonia or urinary tract infection in the winter. The classic mimics to rule out are severe environmental hypothermia, sedative or opioid overdose, sepsis with hypothermia, and primary hypoglycemia. The ITE buzzword is a non-pitting myxedematous edema with a hoarse, slow voice. The Myxedema Coma workup includes thyroid studies, TSH, free T4, free T3. But treatment cannot wait for results. Order a complete CBC, a CMP, including sodium and glucose, ABG for partial pressure of carbon dioxide, as well as pH, a urinalysis, blood cultures, chest x-ray, ECG, and cortisol levels before steroid administration when possible. Look for the triggers, especially infection. The cortisol is drawn before stress dose steroids when feasible to evaluate for concomitant adrenal insufficiencies, but do not delay the treatment waiting for these results. The expected lab pattern in primary myxedema is high TSH with low free T4 as well as T3. The classic distractor is a sick euthyroid syndrome, where TSH is normal or low, free T4 is low or normal, T3 is low, and reverse T3 is elevated. Sick euthyroid is not treated with thyroid hormone, and choosing levothyroxine in that scenario is a trap. The most critical board concept in myxedema coma is to give stress dose steroids before or simultaneously with thyroid hormone replacement. Up to 10 to 15% of myxedema coma patients have a concomitant adrenal insufficiency, either primary autoimmune, polyendocrine syndrome, or secondary from a pituitary disease. Starting thyroid hormone replacement without steroids in an adrenally insufficient patient can precipitate an adrenal crisis or death. The dose of hydrocortisone is 100 milligrams IV every 8 hours, started before or with levothyroxine. The board trap is giving levothyroxine first. The next step framing on the board stem is always hydrocortisone before the levothyroxine, even if the question highlights the thyroid hormone deficiency. Thyroid hormone replacement in myxedema coma uses IV levothyroxine. The loading dose is 200 to 400 micrograms IV over about 5 to 10 minutes. Maintenance is 50 to 100 micrograms, and then they do this daily until they can tolerate oral intake. Some protocols add liothyronine, which is the active T3 form, and they do this with 5 to 20 micrograms IV, then 2.5 to about 10 micrograms every 8 hours. T3 does have a faster onset than T4, the levothyroxine. However, it does have a cardiac side effect profile, so you want to avoid T3 in elderly patients with coronary artery disease. The board concept is high loading dose followed by maintenance with steroids. So airway management is often required in a myxedema coma presentation. This is because they're hypoventilating, causing hypercapnia and respiratory failure. The patients may have an enlarged tongue, which complicates intubation. Sedatives are best avoided or used at a very low dose because they have a prolonged sedation and they further depress that respiration. The board concept is to anticipate the need for intubation and to have a difficult airway plan ready. Etomidate and propofol must be dosed carefully if they're used in these types of patients. So this is one of the times you actually want to be passive and not active. So for rewarming these types of patients, you want to use warm blankets and adjust the room temperature. Because if you use active external rewarming techniques such as heating pads, warm water immersion, or forced air, this will lead to peripheral vasodilation. And in a patient that already has a limited cardiac reserve, this could lead to further hypotension and shock. Supportive care includes fluid resuscitation with cautious isotonic crystalloid, glucose for that sugar, monitoring for arrhythmias, broad-spectrum antibiotics if infection is suspected, and ICU admission. The board concept is passive rewarming with cautious fluids. Hyponatremia is a common occurrence in patients suffering from myxedema coma. It's often severe, especially when that sodium is less than 120 milliequivalents per liter. Due to the impaired free water excretion, treatment depends on the severity of their symptoms. Severe symptomatic hyponatremic patients with seizures or coma require 3% hypertonic saline at 100 milliliters IV. You want to repeat this up to 3 times, and you only want to raise the sodium 4 to 6 milliequivalents per liter. You want to correct it slowly thereafter to avoid that osmotic demyelination. Asymptomatic moderate hyponatremia is treated with cautious fluid management and thyroid hormone replacement. The board concept is to recognize hyponatremia as part of the syndrome and treat the severe symptomatic version aggressively, but with proper limitations. The lab pattern mimics SIADH, low serum osmolality, inappropriate concentrated urine, and a high urine sodium. And the classic distractor is treating it as a pure SIADH, but missing the underlying myxedema. Thyroid storm and myxedema coma require the ICU. The mortality of untreated thyroid storm exceeds 90%, and treatment mortality is still 10 to 20%. Myxedema coma mortality is about 20 to 40, even with optimal treatment plan. Endocrinology consultation is mandatory in these patients, and the board concept for myxedema coma and thyroid storm is that these are not a floor diagnoses. ICU admission is a non-negotiable. The board traps are predictable, giving iodine before or instead of thionamide in thyroid storm. Withholding beta blockade due to AFib when AFib is part of the storm, forgetting glucocorticoids in thyroid storm, giving thyroid hormone before or without hydrocortisone in myxedema coma, active external rewarming in myxedema coma, using aspirin for fever in thyroid storm, heavy sedation in a myxedema coma patient with marginal airways, and failing to identify and treating the precipitating trigger in either syndrome. Iodine first is always the wrong answer. Case 1, we have a 45-year-old woman with untreated Graves' disease presenting to the ED after a recent dental surgery with a fever of 40 degrees Celsius. She's an AFib, she's got some agitation and some pulmonary edema. The correct sequence right now is to administer propranolol 1 milligram IV every 15 minutes until her heart rate's controlled, then PTU 1,000 milligrams orally as a load dose, and then an hour later you're going to give saturated solution of potassium iodine. This is 5 drops orally every 6 hours. You're going to add some steroids, hydrocortisone 300 milligrams IV, then 100 milligrams every 8 hours subsequent. External cooling, Tylenol, IV fluids, and ICU admission, endocrinology consultation, and the search for the additional triggers to be deployed. The board trap is giving the SSKI first. Case 2. A 78-year-old woman with a history of hypothyroidism on chronic levothyroxine is found at home in winter, lethargic with temperature of 33 degrees Celsius, heart rate of 48, and a blood pressure of 85/50. Glucose is 55, sodium is 120. The correct approach is intubation if airways compromised, hydrocortisone 100 milligrams IV first, IV levothyroxine 200 to 400 micrograms over 5 to 10 minutes, passive rewarming blankets only, cautious isotonic fluids, dextrose for her sugar, 3% saline if symptomatic from hyponatremia, broad-spectrum antibiotics for likely sepsis trigger, and ICU admission. The board trap is active rewarming or skipping hydrocortisone. Question 1. In thyroid storm, what must be given before iodine is administered? The answer is thionamide, either PTU or methimazole. The thionamide blocks new hormone synthesis. Giving iodine first or alone provides substrate for synthesis and can actually worsen the storm. The classic wrong answer is going straight for the iodine. Second question. Why are glucocorticoids given in thyroid storm? The answer is twofold. First, they reduce peripheral T4 to T3 conversion. Secondarily, they cover possible relative adrenal insufficiency in the setting of severe hyperthyroid stress. The classic wrong answer is omitting steroids entirely. Question 3. What is the major airway concern in myxedema coma? The answer is hypoventilation with hypercapnia, often requiring intubation. Macroglossia complicates intubation, and sedative must be minimized in these patients. The classic wrong answer here is heavy sedation, which prolongs ventilatory depression and worsens patient outcomes. So here's the takeaways from this lecture. Thyroid storm is a clinical diagnosis using the Burch-Wartofsky score. The treatment sequence is beta blocker, thionamide, iodine at least an hour later, then glucocorticoid. Iodine before thionamide can kill the patient, so don't do that. A myxedema coma patient is typically hypothermic, bradycardic, and altered in the elderly. Give stress dose hydrocortisone before or with levothyroxine. Use passive rewarming. Anticipate that difficult airway. Both conditions require ICU admission and endocrinology consultation. And always look for and treat the precipitating trigger. Sequence is the whole name of the game here. References for this lecture include Rosen's Emergency Medicine 10th edition, Foundations of Emergency Medicine Board Review, the American Thyroid Association Guidelines for Hyperthyroidism Management, the Japan Thyroid Association Akamizu Criteria for Thyroid Storm, the Burch-Wartofsky Point Scale literature, and review articles on myxedema coma management. Local institutional protocols for ICU admission and endocrinology consultation guide site-specific decisions.